Hey everyone, welcome back to PodBites, where we break down complex medical topics into bite-sized pieces perfect for your commute, coffee break, or whenever curiosity calls. I'm your host, Samir Odeh, and today we're joined by our wonderful guest, Mohammed Behairy, and we'll be talking about, drumroll please, the skull.
Thanks, Samir. The skull. Honestly, it's easily one of the most overlooked parts of your body. I mean, hey, it's only holding your brain, your eyes, and literally your entire personality. No pressure, right? Let's walk you guys through everything you need to know about the skull. You could follow along with a picture if you'd like. But for those of you who are driving, please do not pull a picture. Don't worry, we'll try our very best to make it clear and easy for you to follow.
Now, before we get into all the different bones and fancy Latin names, let's talk about the skull's job for a minute, Mohammed.
Just like the rest of your skeleton protects your organs, the skull forms the framework for your head.
So it protects your brain and the cranial nerves and all those other fun stuff.
Exactly. Now, in simplicity, it has three main jobs. Number one is protection of the brain and its meninges. Number two is senses. Basically, the skull houses your special senses, from seeing to smelling, tasting, and hearing. All of these important senses are controlled by the cranial nerves that are passing through the skull. Last but not least, it guards the entrances to your digestive and respiratory systems. The skull forms the framework around the mouth and nose, making sure that air and food get to where they need to go.
Now, I'm assuming there's some organization for all this stuff, and it's got different sections for all these structures. Right, Mohammed?
Exactly, absolutely. You should also remember that when we say skull, we're not just talking about the part that's around the brain, we're also talking about the face. So we have an area of the skull specifically for the brain, which we refer to as the neurocranium, and then another area, completely different, for the face called the viscerocranium, which houses the entrances for air and food.
Wow. So to know which one is for which, just think neurocranium for the neuro part, aka the brain. Okay, so we said that the neurocranium is the part that covers the brain. This part of the skull is made of 8 bones.
Exactly. And if you arrange their names in a certain way, they kind of spell out step off. So that makes them easy to remember. S for the sphenoid bone, T for the temporal bone, we have two of these guys by the way,
Mhm.
E for the ethmoid bone, P for the parietal bones, we also got two of those, O for the occipital bone, and lastly F for the frontal bone. So we've got one of each except for the temporal and parietal bones. They're paired, so that makes a total of 8 bones.
Ah, 4 unpaired bones and then 2 pairs of bones. And I noticed that most of their names are actually the same as the lobes of the brain.
Good catch. Each lobe has a specific bone overlying it, hence why they have the same name.
I guess it makes our job of remembering them a tiny bit easier, I guess.
I guess so.
So these are all flat bones, right?
Yup, they're all flat bones, joined by sutures, and they have a spongy layer inside of them called the diploid.
You know, I like to think of flat bones like a sandwich, where the compact bone is like the toast on both sides, and the diplo is like the cheese in the middle. Soft, but still holding everything together. But I guess it's not as tasty as a sandwich, though.
That's so creative of you, Samir.
All right, now let's go through each of these bones and their clinical relevance, starting with the frontal bone.
The frontal bone forms your forehead and the roof of the orbits, which are essentially your eye sockets. The frontal bone usually is not paired, it is just one bone, but it starts as two separate bones with a suture in between, called the metopic suture, which usually fuses by the age of 8. However, fun fact, 8% of people get to keep it for their entire lives. Oh, and don't forget the frontal sinuses. These are right behind the frontal bone and extend into the roof of the orbit, so they're right underneath your eyebrows.
Okay, so frontal bone is in the front, basically your forehead. Now, what about the parietal bone?
We've got two parietal bones, one on each side, left and right. They meet at the sagittal suture right down the middle of the skull. This sagittal suture runs from front to back.
Aha. So for the frontal bone, we had that metopic suture, but that one disappears. Whereas in the parietal bones, the sagittal suture sticks around?
Exactly.
Great. Now let's move on to the occipital bone, which is the big bone at the back of your forehead.
The occipital bone has a big opening in the midline called the foramen magnum, through which the spinal cord exits.
Now, foramina are essentially tunnels that nerves and vessels use to get in and out of the skull. They're usually pretty small, but this one is bigger because we need to fit the whole spinal cord. So remember that the biggest foramen is called magnum because it's mega. And it's for the spinal cord because the spinal cord is bigger than all the other cranial nerves.
The occipital bone also has something called the occipital condyles, which are like articular surfaces on either side of the foramen magnum. These form one of the several joints that connect the skull to the neck, and this joint, with the occipital condyles, allows you to nod yes. Also, the word condyle essentially means a part of the bone that makes a joint with another bone, so that makes sense.
Okay, so the occipital bone has the foramen magnum for the spinal cord, and the condyles to form a joint with the neck and help us nod.
Hmm.
Most of the bones of the skull, as you'll see now, have different parts. So let's discuss the parts of the occipital bone.
Okay, we can split the occipital bone into three parts. First, we have the basilar part, which is the narrow part that meets with the sphenoid bone anteriorly. We'll cover the sphenoid bone in a bit. Then, we have the lateral parts, which have the condylar surfaces on either side of the foramen magnum that we just talked about. And finally, we have the squamous part, which is the largest part at the back, and it's broad and flat like a plate.
Oh yeah, squamous as in flat, and that's also why squamous cells in histology are flat. It's the same name.
Exactly. I guess all these names are starting to make sense after all.
So, don't forget, just like Mohammed said, the occipital bone has three parts: the basilar part, the squamous part, and the lateral parts, which we have two of, one on each side. Now, going to the next bone, the temporal bone. That's the one just above and around the ear.
Remember that we have two temporal bones, one on each side, just like we had two parietal bones.
Oh yeah, so two temporal bones because we have, well, two ears. It's obviously going to have different parts, just like the occipital bone as well.
Which is a bummer for us, and it's kind of a heavy one too, but we can break it down. Each temporal bone has four parts. First, we have the squamous part, which is right above the temporomandibular joint, or the TMJ for simplicity. Then, we have the tympanic part, which surrounds your external ear canal, aka the external acoustic meatus.
So the external acoustic meatus is inside the tympanic part of the temporal bone.
Yup.
Okay, so we talked about the squamous part, which has the TMJ, the cool acronym that Mohammed talked about. And we also have the tympanic part, which has the external acoustic meatus. Let's continue with the rest of the temporal bone.
Alright, we also have the mastoid part of the temporal bone. The mastoid is that hard bump you feel right behind your ear, and it's full of air-filled cavities called the mastoid air cells.
You know, I'm looking at the inside of the mastoid bone, and it kind of looks like a honeycomb.
Yeah, that's one way of looking at it. And finally, we have the petrous part. This is where we can find the inner ear and the internal acoustic meatus, plus some important structures related to the inner ear, like cranial nerve 7, which is the facial nerve, and cranial nerve 8, which is the vestibulocochlear nerve.
The petrous part also has the carotid canal.
Yeah,
So wait, the external acoustic meatus is in the tympanic part, while the internal acoustic meatus is in the petrous part.
well done, Samir.
The petrous part has a bunch of important stuff with the inner ear, like the cranial nerves 7 and 8, so it must be super important clinically, right?
Oh boy, it is. A fracture here can lead to serious issues, like cerebrospinal fluid or blood leaking from the ear. If there is damage to cranial nerve number 8, you can get hearing loss. Or if there is damage to cranial nerve 7, you can even get Bell's palsy, which causes facial drooping.
So remember, both Bell's palsy and hearing loss can be caused by damage to the petrous part of the temporal bone.
Yup. Now, let's discuss the sphenoid bone.
Oh wow, this one looks like a butterfly.
It really does. And it's also kind of another heavy part of the skull because it has some important stuff. And again, like all the previous bones, we can divide it into parts. So we have the sphenoid sinuses, which should be easy to remember because they have the same name. Then it also has the sella turcica in the center, and that holds your pituitary gland. Finally, it has two wings on either side of the sella turcica, the lesser and greater wings.
Sphenoid sinuses, sella turcica, lesser wings, greater wings. The greater wings must have some major foramina inside of it, right?
Yeah, it actually has three foramina through which some important structures pass. First is the foramen rotundum, or the maxillary branch of the trigeminal nerve, which is cranial nerve V2. Then there is foramen ovale, for the mandibular branch of the trigeminal nerve, which is cranial nerve V3. And finally, foramen spinosum, for the middle meningeal artery.
So in the sphenoid bone, we should think of the trigeminal nerve. And then when we think rotundum for the maxillary branch and ovale for the mandibular branch.
Absolutely. And don't forget the middle meningeal artery goes through the foramen spinosum.
Perfect. We're at the last bone now, the ethmoid bone. This one is related to the nose.
It kind of sits between your eyes and forms a big part of both the nasal cavity and the orbit, the eye socket essentially.
Whoa, important. What are the different parts of the ethmoid bone?
Good question. First, we've got the cribriform plate, which looks like a sieve at the roof of the nasal cavity. It's full of tiny holes called olfactory foramina, where the olfactory nerve fibers pass through to reach the brain. So it's important for your sense of smell.
Wait again. The olfactory nerve fibers are coming from the nose after sensing smell and going to the brain via the olfactory foramina in the cribriform plate of the ethmoid bone.
Exactly. Then we have a perpendicular or vertical plate that projects downward from the ethmoid bone, and we literally just call it the perpendicular plate. This plate helps form the nasal septum, the wall that divides your nostrils. Then, on either side of this perpendicular plate, we have the ethmoidal labyrinth. This part holds the ethmoid air cells.
The ethmoid air cells are kind of like tiny little sinuses.
Yeah, they are. The ethmoid bone also gives rise to the superior and middle nasal conchae, which are curved bony shelves inside your nose that help humidify and filter the air you breathe.
We said that the ethmoid is also related to the orbit.
It contributes to the medial wall of the orbit, so you could say it helps shape both your nose and eyes.
Alright, so remember that the ethmoid bone has the cribriform plate where all the olfactory nerve fibers pass through, and then the perpendicular plate that forms part of the nasal septum. And on the sides, we have the ethmoidal labyrinth. The ethmoid bone also forms a superior and middle nasal concha. Oh, and don't forget that it contributes to the medial wall of the orbit.
And this is actually very clinically important in cases of infections like orbital cellulitis, because this thin bone there can allow infections from the ethmoidal sinuses or air cells to spread into the orbit.
Okay, that makes sense entirely.
And guess what? We just covered all of the bones.
Finally! Let's talk briefly about how they're all joined together to make one skull. We kind of mentioned some of the sutures that joined them, but let's dig deeper into that.
Sure thing, Samir. So you know how we always see through squiggly lines on the surface of the skull? Those are the sutures, where the different bones of the skull meet.
So we can think of them like the skull's version of a jigsaw puzzle.
Nice analogy, Samir. Let's start with the coronal suture. This one is between the frontal bone and parietal bones. Imagine it like a crown or a headband. Then we have the sagittal suture between the two parietal bones. Remember we said this one is right in the middle of the skull, from front to back.
Okay, so the coronal suture is like the line that you would draw if you wanted to cut the skull in a coronal section, while the sagittal suture is a line that you would draw for a sagittal section.
Exactly. Then we have the squamous suture between the parietal and temporal bones.
So we would have two of the squamous suture, one on each side, right above the ears, well, because we have two temporal bones.
And finally, we have the lambdoid suture at the back between the parietal and occipital bones.
Wait, Mohammed, this one looks like an upside down V.
Now that I think of it, it does. It's actually named after the Greek letter lambda.
All of these sutures have some soft spots in babies' heads, right? To allow for flexibility during the birth, since the birth canal is relatively narrow.
You're right. Those spots are what we call fontanelles. And we have two main ones, the anterior fontanelle and the posterior fontanelle. Keep in mind that the posterior fontanelle closes first.
So when does each of these fontanelles close?
The anterior fontanelle closes by 18 months, whereas the posterior one closes by 2 months.
So what happens if they close earlier or later than they should?
If the fontanelles close too early, it's called cranosynostosis. But if they stay open for too long, that would signal hydrocephalus or hypothyroidism.
Alright, now let's shift and talk about the inside of the neurocranium. When we look at its base, or basically the whole internal surface, we can split it into three parts: the anterior cranial fossa, the middle cranial fossa, and the posterior cranial fossa. Let's start by going over the anterior cranial fossa.
The anterior cranial fossa forms the front row of the base. It mainly holds the frontal lobes of the brain and has a few key structures like the cribriform plate of the ethmoid bone, which, if you remember from earlier on, allows for the passage of the olfactory nerve.
Alrighty, so we've got the cribriform plate. What else is in the anterior cranial fossa?
Another small structure here is the foramen cecum, which isn't just a random hole. In some people, it lets in tiny emissary vein that connects the nasal cavity to the superior sagittal sinus. And on the other side, we've got the anterior and posterior ethmoidal foramina. These are the delivery portals for ethmoidal nerves, arteries, and veins that go to supply parts of the nasal cavity and the orbits.
And I'm assuming that this area is super clinically important, especially in trauma cases, right?
Absolutely. A fracture of the anterior cranial fossa, especially through the cribriform plate, can lead to three major complications. First of which, anosmia, which is the loss of smell due to damage to the olfactory nerves. Second of all, periorbital bruising, also known as raccoon eyes. Last but not least, CSF rhinorrhea, which is essentially when the CSF starts leaking out from the nose, and that's a serious and key sign that there's been a skull-base fracture.
Right on. So if you see a patient with clear nasal discharge after head trauma, always think of a possible anterior cranial fossa fracture. Now let's go back to the middle cranial fossa.
Okay, the middle cranial fossa holds the temporal lobes and is home to a ton of important foramina. Let's cover the most important ones. Firstly, we have the optic canal. This is where your optic nerve, cranial nerve number 2, and the ophthalmic artery pass through to get into the orbit. It's how your brain talks to your eyes, essentially. And just next to it is the superior orbital fissure, and this one's a highway because it transmits a lot of the cranial nerves, like cranial nerve 3, the oculomotor, cranial nerve 4, the trochlear, cranial nerve 6, abducens, and the ophthalmic division of cranial nerve 5, which is also V1, plus some ophthalmic veins.
Okay, so far the names make sense. The optic canal carries the optic nerve, and the superior orbital fissure basically carries all the nerves related to the orbit, which we said is the eye socket. So it's 3, 4, 6, and V1. What's next?
Next, we have the three foramina that pass through the sphenoid bone. Do you remember what they are?
Oh yes, rotundum, ovale, and spinosum.
Good job, Samir. And as you know, the foramen rotundum allows for the passage of the maxillary division of cranial nerve 5, which is V2. And below it, the foramen ovale is where the mandibular division, V3, of the trigeminal nerve passes, along with the accessory meningeal artery. And right behind that is the foramen spinosum, which is a very crucial foramen because it carries the middle meningeal artery, the one most commonly torn in epidural hematomas.
Ah, that's the one that leads to that lucid interval, right? Like a drama movie where the victim is fine and living their best life at first, but then everything suddenly starts going wrong.
Yup, that's exactly the one. You know the drill. Someone gets hit on the side of the head, the middle meningeal artery tears, and blood starts quickly pooling between the dura and the skull.
Yup, the patient may seem fine at first, but then it all goes south pretty quickly. Classic emergency.
It is also worth mentioning that the carotid canal runs just nearby, transmitting the internal carotid artery into the skull, accompanied by sympathetic fibers. Oh, and the foramen lacerum. It's one of those strange holes where nothing really passes through it directly, but the internal carotid artery runs over it, along with the greater and deep petrosal nerves heading toward the pterygoid canal.
Got it. Wow, that's a lot of structure in the middle cranial fossa. Alright now, time for the final part, the posterior cranial fossa.
This is the deepest and largest part of the cranial base, and it houses the cerebellum, pons, and medulla. Basically, all the essential brain parts. So, yeah, this area is pretty important.
All right then, I'll be sure to really lock in for this one. What major openings do we have here?
First, we have the internal acoustic meatus. This one transmits both cranial nerve 7 and 8, the facial and vestibulocochlear, plus the labyrinthine artery. So any problems here could mess with your hearing, balance, and facial movements.
Okay, so the acoustic part of this means sound. So it makes sense that the nerves here are related to hearing and balance.
Exactly. Next, we have the jugular foramen. This one's pretty big. It carries cranial nerve number 9, the glossopharyngeal, cranial nerve number 10, the vagus, and cranial nerve 11, the accessory nerve. Plus, the start of the internal jugular vein. A lesion here could cause a whole set of lower cranial nerve problems. The hypoglossal canal, as the name clearly suggests, carries the hypoglossal nerve, or cranial nerve 12, which controls tongue movement.
Sounds pretty significant. So what happens if this hypoglossal nerve gets injured?
If it's damaged, the tongue will deviate towards the injured side. And yes, that's where the mnemonic lick your wounds comes from. And finally, the foramen magnum, the largest hole in the skull. Do you remember what that's for?
Ah yes, the spinal cord.
Exactly. And other than the spinal cord, we also have the vertebral arteries and venous plexus.
Oh dear, so trauma to the base of the skull can hit some pretty high priority stuff.
Unfortunately. And the symptoms will depend on where the fracture occurs and what structures are affected, whether it's CSF leakage, nerve palsies, hearing loss, or brainstem compression. Knowing the layout of the cranial base helps you localize the injury pretty fast. That's why it is imperative for us to familiarize ourselves with its anatomy.
Alright then, so to wrap it all up, here are 3 common fracture zones you want to remember and their associated symptoms. Firstly, a temporal bone fracture, or the petrous part specifically, where you get CSF leakage from the ears, hearing loss, and Bell's palsy. Next up, we have an anterior cranial fossa fracture, which is mainly to the cribriform plate, where you get anosmia, raccoon eyes, and CSF leakage from the nose. Finally, we have a pterion fracture. This is the most dangerous because it's the thinnest area of the skull. It can lead to a rupture of that middle meningeal artery, resulting in an epidural hematoma, which, if you remember, is followed by a lucid interval and then a brain herniation if left untreated.
Wow, Samir, you did an amazing job summarizing these. Glad to see that my work here was useful.
Alright then, let's move to the face. This part gets all the attention anyways, especially when it comes to the selfies.
That is true. Well, the viscerocranium forms the front of the skull, basically your face, the mouth, nose, and orbits. It's made up of 14 bones, and if you ever need to impress someone with your anatomy knowledge, here's the list. We've got 2 lacrimal bones, which are the tiniest, but they help us with tears. 2 nasal bones, because obviously you need a nose to breathe and smell. 2 maxillae, making up the upper jaw. They're the bones that hold your teeth in their places. 2 zygomatic bones. These guys will make up your cheekbones.
I mean, hey, who doesn't love a good cheekbone highlight?
I agree. Then we've got 2 palatine bones, which are very deep in there, forming part of your hard palate or the roof of your mouth. We also have 2 inferior nasal conchae. These guys help filter and humidify the air you breathe through your nose. Then we have a singular mandible that makes up your lower jaw, the one you're always using to chew and talk, like we are right now. And lastly, a singular vomer, which is a small bone that helps form part of your nasal septum.
That sure was an exhaustive list. Thank you, Mohammed. So, just to recap, we've got 2 lacrimal bones, nasal bones, maxillae, zygomatic bones, palatine bones, and inferior nasal conchae. We also have a singular mandible and vomer.
Yup, exactly. And let's not forget the key foramina on the face. The supraorbital foramina beneath your eyebrow area, basically above the orbit for the supraorbital nerve vessels from V2. The infraorbital foramina below the eyes or orbit for infraorbital nerves and vessels, also from V2. The zygomaticofacial foramina for the zygomaticofacial nerve, once again from V2, and finally the mental foramina at the chin for the mental nerve and vessels from V3.
So basically, your face is not just good for showing off your smell. It's a pretty busy, nerve-filled area. Alright, so how does this whole skull business even form? Like, where does it all even begin?
Great question, Samir. Well, it's a bit of a two-part process. The cranial base forms through endochondral ossification, which is a fancy term for when cartilage is slowly getting replaced by bone. Think of it as a cartilage skeleton turning into a solid bone structure. On the other hand, the cranial vault and face are formed through intramembranous ossification. This means that the bones form directly from the mesenchymal cells without a cartilage intermediate. So, no cartilage blueprint here, just a direct build.
Okay, so endochondral is from cartilage, which makes sense since chondro means cartilage and intramembranous is directly from mesenchymal cells, which are basically cells that can turn into either bone or cartilage. I also find it pretty fascinating that sutures and fontanelles let the skull bones grow and shift during birth. It's so cool how the skull can mold into exactly the right shape. Alright, I think that's pretty much it. Any last minute need to knows? We don't want to miss any points.
Of course, Samir, these three skull landmarks are very important to know. Just make sure to keep them in mind. First, we have the bregma, which is the junction of coronal and sagittal sutures. Second, we have lambda, which is essentially where the sagittal and lambdoid sutures meet. Last but not least, the pterion, and this one is very critical. As we mentioned earlier, it is the thinnest point of the skull, and it sits right over the middle meningeal artery.
And that's a skull, our very own protective and functional helmets. It's kind of like a head hat, right? Except it doesn't come off and you won't lose it in a construction site.
That's pretty much it. Okay, so let's just have a quick recap of some key points before you guys get sick of us.
Let's do it. Firstly, the skull is made out of the neurocranium, composed of 8 bones, and the viscerocranium, composed of 14 bones. Secondly, sutures and fontanelles are important for growth and flexibility during childhood. Thirdly, dangerous fractures would happen at the pterion, the petrous, and the cribriform plate.
Well said, Samir.
And that's a wrap on the skull. Thank you for tuning in to another episode of PodBites. Don't forget to follow us and give us a review so we can improve with each episode. Until then, keep your heads high and your skulls intact.
See you all next time.